Good evening, everyone. Welcome to ALTSI. My name is Sean Smith. I'd like to thank the organizing committee for the opportunity to present this short talk on mass casualty mechanical ventilation, and thank you for making the time to listen. I will be available for questions in the allocated time for questions and answer and discussion. Disclaimer, content of my presentations does not violate any proprietary rights. I comply with HIPAA, refrain from using names, patient identifiers, etc. No off-label uses, no financial disclosures or conflicts of interest. So again, no conflicts. Many thanks for your gracious invitation and appearance. Sean Smith, flight nurse, paramedic. What's most important to you about my background is I actually started out as a research scientist in molecular neuroendocrinology, and from there went on to study nuclear engineering in the United States Navy. So I sort of take a blended approach to critical care that relies heavily on physics and physiology. Okay? I've structured my life so that I can spend about half my time doing humanitarian and charity work, and that ties directly into this presentation. If you are interested, obviously this is a super brief introduction. I'm just hitting high points. If you'd like more, I developed using readily available resources, some of which I give you here. I developed an entire SARS-CoV-2 curriculum for the Guyana Ministry of Health with mechanical ventilation. And of course, I'm also more than welcome. I have tons of PDF files, etc., that are totally, we have the author's permission to redistribute them, things like that. So you're welcome to that compendium on request as well. How can you request it? I have my email address at the bottom of the slide. The profile picture that you see in the upper right-hand corner of the slide, that's my Facebook picture. You're welcome to find me on Facebook, welcome to email me. Again, also, I'm always looking for collaborators to develop the various places that I work, Haiti, Guyana, Nepal, etc. So please don't hesitate to reach out to me if you would like more resources than what I provide in this presentation, or if you would like to be a part of my ongoing humanitarian education efforts. The other images that you see on this slide, this is me administering surfactant to a premature neonate in Haiti, which ironically enough is very relevant to this presentation. There's a lot of corollaries between surfactant deficiency pathologies in premature babies, as well as ARDS, ventilator-induced lung injury, etc. The next slide down, the next image down, of course, just a picture of Liberia, where I worked with the World Health Organization during the last Ebola outbreak, the last major Ebola outbreak, not counting the current ones in Democratic Republic of Congo, of course. And then the lower left-hand corner, what we're really going to be focusing on, we've got approximately 20 minutes. We're doing pearls, guys, pearls. I am giving you, hitting it hard and heavy, and giving you pearls and things to think about. Okay. Co-instructors will be Albert Einstein and Steve Jobs. Steve Jobs said, stay hungry, stay foolish. Steve Jobs also emphasized elegance and simplicity, as did Albert Einstein. So we'll be exploring those themes. Simple can be harder than complex. You have to work to get your thinking clean to make it simple. And that's why I emphasized that I had an engineering background as well as a molecular neurobiology background, is the more you know, actually, the simpler it gets, right? The more we can drop things down to first principles. People look at mechanical ventilation, and it can be very scary, right? It can be just an avalanche of information. No. Just like a neonate learns by forming neural networks and associating experiences, that's also how we learn as adults. So what we're going to try and do is work hard, get our thinking clean, and embrace some new things by associating them with things that we already know. We're going to fly, but the emphasis is not going to be on memorization. It's going to be on understanding, right? It's the difference between being a clinician and a technician. proactive versus reactive, mastering versus memorizing. Okay? One of my favorite quotes, sometimes you need to talk to a 2-year-old just so you can understand life. Very important for this presentation. What do 2-year-olds always ask? Why? So I always want you to ask why we're doing things, and then I want you to think like a 2-year-old engineer. Think about the system implications, not just the microcosm that you're looking at in the moment, but the big picture. How does it connect? And that becomes really important when we start talking about mechanical ventilation in mass casualty situations. Remember, the correct answer is always cerebral perfusion. Cerebral perfusion, of course, things flow down concentration gradients. So the pressure in this box minus the pressure in this box, right? MAP minus ICP. What determines that? Cardiac output, heart rate, and stroke volume. Stroke volume, of course, being preload contractility after load. We'll touch on all of those concepts tangentially as we move along. Our main focus, again, is going to be on that mass casualty ventilation to optimize cerebral perfusion, because, of course, that's our only goal in a resuscitation scenario or a mass casualty scenario. Albert Einstein said, if you can't explain it to a 6-year-old, you don't understand it yourself. Honestly, guys, I hate PowerPoint. I wish I could just walk into a room with you, have a dry erase board, chalkboard, and go, what do you want to know? Let's go. Boom, boom, boom. Open dialogue, right? But I'll do the best I can. Make everything as simple as possible, but not simpler, right? Education is not the learning of facts. It's training the mind to think. Or as I said earlier, don't memorize it. Master it, understand it. Novices, what we're going to work on for you guys, conceptualizing, we're going to demystify by helping you learn by association, connecting those dots, forming those neural networks. For novices and experts, I want you to kind of get some teaching methodology out of this, as well as embrace some considerations unique to disaster medicine and mechanical ventilation. First principle is going to be 3 things we talk about. Obviously, mass casualty medicine, greatest good for the greatest number. Second, first, do no harm. And third, medicine is meant to match homeostasis. Never lose track of everything we're doing. Is meant to provide respite for the body by duplicating the body's functions until it can resume them on its own, right? That's also a key component of triage. You know, what is the projected clinical course? Is the body likely to resume pre-insult function on its own, and if so, with what degree of deficit and meaningful, right, existence. All right, indications for mechanical ventilation. I just went ahead and screenshot this off open anesthesia. I think everyone's very familiar with this. What are we talking about? The right answer is always perfusion. What does perfusion mean? Get oxygen in, get CO2 out. Oxygen in, type 1 failure. You might hear about types of respiratory failure. Type 1 failure, failure to oxygenate. Type 2 failure, failure to ventilate. And of course, if they can't protect their own airway. Big warning flags we need to think about 50-50. PO2 lower than 50, CO2 higher than 50, okay? Unwarranted tachypnea, right? They're not compensating for metabolic acidosis, for example. SATs less than 90. You may not realize it, but SATs less than 90 actually correlate to a PO2 of approximately 50 to 60, depending on where you're at in the world and what else is going on with the patient. That relationship's on the basis of the oxyhemoglobin dissociation curve, which I'll show you later. First principles, again, medicine matches homeostasis. Get oxygen in, get CO2 out, type 1, type 2. We're going to learn by relating, and we're going to start right now. I want you to think of invasive mechanical ventilation as a continuum. Now, we're going to make some assumptions here. We're going to do volume control and SIMB. We're going to assume a set short rise time and optimal trigger sensitivity. Those are all reasonable assumptions. There is a high probability that you could encounter a wide degree of different ventilators in a mass casualty situation, depending on the environment, government stockpiles, NGO stockpiles, etc. You may wind up with the absolute best ventilators in the world, like a Hamilton T1 or ICU level Puritan Bennett's, et cetera, or you may wind up with a very primitive ventilator, but they will all do SIMV volume control with a default rise time and trigger sensitivity. Volume control's intuitive, right? It's very simple. Cardiac output, I says heart rate times stroke volume. You can think of pulmonary output as the same way. Respiratory rate times tidal volume. So if I want to get CO2 out, I'm going to optimize respiratory rate and tidal volume. Same formula for any pump, rate times volume, okay? Why do I say SIMV? It's semi-homeostatic, okay? It allows the patient to breathe on their own. It's not, and again, I said SIMV because you can find it on any vent. Obviously, there are modes that more closely replicate homeostasis than SIMV, but I'm picking a constant to begin with because we only have 20 minutes, right? Normally when I do something like this, we have more than 20 minutes and I do it as a hands-on teaching lab. And again, if you contact me offline, I'll be happy to pass on some curriculum to you, things like that, okay? The other thing so SIMV lets the patient take breaths, which helps prevent deconditioning, okay? It's still a positive pressure breath. Naturally, we're negative pressure breathers, so not completely homeostatic, et cetera, but, okay? What might be some circumstances if the patient's not breathing on their own? For example, and the nice thing about SIMV is it's going to give set breaths, set volumes, set rates, if the patient's not taking a breath on their own. For example, if we had a traumatic brain injury with a reasonable chance of successful outcome, or we could afford to give up the vent on this patient with a traumatic brain injury. Of course, why am I saying that? Because often traumatic brain injuries in triage, we write them off, right, unfortunately. But just hypothetically speaking, if I had a patient with no respiratory effort, say traumatic brain injury, and we were trying to prevent diffuse axonal injury, I could do ACV. Of course, SIMV would be ACV by sedating the patient and putting them in that neuroprotective coma. Now, what I want you to think about, this is the nuts and bolts of this presentation. 4 ways to improve oxygenation, 4 ways to improve ventilation, and it's all on a continuum. You're not doing anything with that ventilator in an ICU or in a field hospital that you aren't doing in a primary care outpatient clinic. It all duplicates homeostasis, okay? So let's start with oxygenation. Hypothetical patient walks into your outpatient clinic. They were running late for their appointment, breathing fast, etc., right? Their sats are a little low. So what do you do? What do? You tell the patient to take a couple slow, deep breaths, right? Okay. Slow, deep breaths. Now, just hypothetically speaking, say that didn't work. What might you do? You might give the patient a couple liters of oxygen by a nasal cannula, right? Particularly if there were other things in the history and physical that indicated it. Now, let's say that the nasal cannula didn't work. Well, what would be the next step? We're not going to go straight to intubation. What would we think about? We think about non-invasive positive pressure ventilation, right? Non-invasive positive pressure ventilation. And if the patient failed non-invasive positive pressure ventilation, then we would think about intubating, right? Now, how does that tie into the 4 ways to improve oxygenation? Very simple. And you'll want to write these down. And again, I come at it from an engineering point of view. And the reason I do that is if you understand the physics, the knobology, the differences between different vents doesn't matter, right? You can look up how to make the knobs adjust what you're trying to. So we've got 4 ways to adjust oxygenation. Increase FiO2, increase inspiratory time, increase inspiratory pressure, and PEEP. FiO2, pretty obvious, give the patient more oxygen. Inspiratory time, I'm inhaling longer. I'm going to get more oxygen in. Inspiratory pressure, I'm inhaling harder. I'm going to get more oxygen in, right? You'll hear this called mean airway pressure, okay? And then, of course, PEEP ties into mean airway pressure, but I'm breaking them up for different reasons, okay? PEEP does a few things to us. It helps keep the airways open, right, which improves airflow, and I'll show you that later, but it also keeps the alveoli open, which increases your cross-sectional surface area for gas exchange. You just made your filter bigger, right? Basic Engineering 101 all along all an alveolar capillary membrane is a cross-current filter. It's just like your glomerular basement membrane, actually. Look up Goodpasture syndrome if you got nothing better to do and want to play medical detective. 4 ways to improve ventilation. Opposite side of the coin, okay? Let's say you got a patient, known COPD, comes into your clinic, right? Their CO2 is high, they're having some issues. How would we ask that patient to breathe, right? Pursed lipped breathing, pursed lipped breathing, okay? And when I do pursed lip breathing, what am I doing? Increasing expiratory time and expiratory pressure. So does it make sense that if increasing inspiratory time and inspiratory pressure gets O2 in, that increasing expiratory time and expiratory pressure is going to get CO2 out? Absolutely. And then, of course, remember the lungs are like a pump. So what would the other 2 of my 4 be? Rate and volume. So what are my 4 ways to get CO2 out? Increase rate, increase volume, increase expiratory time, increase expiratory pressure. Just the flip side of that oxygenation issue, right? So 4 ways to improve oxygenation, 4 ways to improve ventilation. Okay. Again, think about how we breathe. We're negative pressure breathers. Boyle's law. Things flow from high to low. So in order to take a breath, I have to induce a lower pressure in my thoracic cavity than atmospheric. How do I do that? Boyle's law. Pressure and volume are inversely proportional. So I make the chest cavity bigger, right? Volume goes up, pressure goes down. Okay. What are things that would interfere with that? Well, neurogenic. My phrenic nerve doesn't fire, so my diaphragm doesn't go down, my intercostals don't go up and out. I could have burns and require an escherotomy. I could have broken ribs, right, that made it painful to breathe. I could I could have ARDS, right? And I always tell people to think about this because we're going to get into alarms in a minute. Think about it like blowing up a balloon through a straw. The pressure that it takes to inflate that balloon is a mix of 2 things, right? It's a mix of overcoming the resistance of the straw and the compliance of the balloon, okay? And when we talk about compliance and the types of injuries that we often see in mass casualty situations, pulmonary trauma, inhalation injuries, things like this, we need to think of lung protective ventilation. My apologies for using an abbreviation there. I believe I spell it out for you later. Lung protective ventilation due to reduced compliance. Okay? And we'll talk about overcoming resistance issues, right? I can do that by adding pressure support on the vent, by intubating early, right? Big is better, right? Cross-sectional diameter is the single biggest determinant of flow in a tube. Okay? What are we worried about? We want to get good oxygenation, but the problem is we also want to get CO2 out. So how can I balance those 2 without causing ventilator-induced lung injury, like volume trauma, from using high tidal volumes? What are some of the strategies we can use? Lung protective ventilation strategies. Okay. Well, one strategy we can use right off the bat is early proactive non-invasive positive pressure ventilation. And that also helps conserve our vents. Okay. Now, what helps conserve our lungs? Permissive hypercapnia, letting the CO2 accumulate, because the deleterious effects of the high CO2 are balanced by the fact that we're not damaging the lung, not causing ventilator-induced lung injury. Same thing, permissive hypoxemia, right? We have to be careful about how much PEEP we use. Low tidal volumes, okay? And I tell you exactly what I mean there. 5 mils per kilo versus 7 mils per kilo ideal body weight. ARDSNet, which is a PEEP versus FiO2 protocol based on low tidal volumes. I give you that reference later. We can think about things like inverse ratio. Very simple. That's some big scary words. Don't let it scare you. Pretty simple. Okay. A breath consists of inhaling and exhaling. We call that the I to E ratio. Normal ratio on an adult's about 1 to 3. Well, if I was having problems with oxygenation, I could increase my inspiratory time, which, if you remember, is one of the 4 ways to improve oxygenation. Of course, if you have more advanced vents, you can look at other modes like airway pressure release ventilation or high frequency ventilation, oscillatory ventilation. Okay. Going back to our 3 principles, right? First principle is understand basic physics and physiology. Now, what are we here for? Mass casualty. By definition, you're in a resource-limited environment. We got to triage equipment and patients, right? Goes hand in hand, right? We're looking at the projected clinical course, endpoints, futility of resuscitation, what interventions are required, comparative survivability, allocation of resources. Please, when you think about projected clinical course, think about things like blast injuries, blast lung, broken ribs, pulmonary contusion. Those patients are walking wounded, but they may very well need some form of ventilatory augmentation. Inhalation injuries, we need to intubate sooner, earlier than later because of that rapidly decreasing cross-sectional area that I mentioned earlier. Do not forget transfusion-associated problems. Okay, we're talking about mass casualty, and we're talking about being proactive, not reactive, being a clinician, not a technician. Don't forget about TACO and trolley, right? Transfusion-associated circulatory overload, which can lead to ARDS, ARDS, and transfusion-related acute lung injury. So keep an eye out for those things. And we're going to talk about how to keep an eye out for those things under step 2, first do no harm. Okay, some things to think about in terms of triage, non-invasive positive pressure ventilation. Use it early, use it aggressively. What are some things that are going to optimize it? First off, infection control is not an absolute contraindication. Infection control can be managed depending on what's going on, what scenario do you find yourself in, etc. So we've discussed that earlier in another presentation I did on the current pandemic. Some drugs that you may want to think about in terms of augmenting your non-invasive positive pressure ventilation. Anxiolytics, right? We're normally negative pressure breathers. Non-invasive positive pressure breathing is very unsettling to the patient. So very low dose benzos or ketamine will make them more compliant and help them synchronize with the therapy. If they have concomitant trauma, especially to the rib cage, definitely think about multimodal pain management, NSAIDs, peripheral nerve blocks, okay, hand in hand, okay? Remember, when you're talking about musculoskeletal injury, the primary signaling agent is prostaglandins, right? And NSAIDs interfere with COX-1, COX-2 pathways and reduce the production of prostaglandins. I'll show you a thing on that later. And then, of course, antiemetics. And these aren't all slam dunks, but definitely things to think about, right? Why would we think about antiemetics? Because I'm given that positive pressure ventilation, gastric insufflation, the patient can vomit. Now, yes, the machine will shut off, right, when the back pressure will trigger it to shut off, but will it shut off before the patient aspirates? So sometimes we think about prophylactic antiemetics. Prophylactic antibiotics, depending on the situation, again, it's a tightrope. We're worried about multi-drug resistant organisms and antibiotic stewardship, so something to think about there. Corticosteroids, recent trial, of course, DEXA-ARDS trial, showing that corticosteroids did improve outcomes in ARDS patients. And keep in mind that in this sort of situation, we are likely to encounter ARDS-type pathology. Here, the Hagen-Pusslier equation on the left showing you why we intubate early in inhalation injuries. When you look at this, pressure differential equals 8 times the dynamic fluid viscosity multiplied by the length of the tube multiplied by the volumetric flow rate divided by pi times radius to the 4th. So what is the single largest determinant of pressure differential, which is what determines the flow? Things flow from high to low. Radius to the 4th power. So when we think about proactive and being a clinician, not a technician, again, those signs and symptoms of ventilation injury, inspiratory stridor, soot, things like that, we want to intubate early, go big, go home. Here, I just give you a chart from the United States Department of Defense going through the different types of blast injury. And why am I doing that? A couple things to think about. Blast lung, okay, primary injury. And then, of course, secondary injury, flying debris, hitting ribs, pulmonary contusion. Tertiary injuries, the person being thrown, breaking ribs, pulmonary contusion, et cetera, et cetera, et cetera. Okay, so important to keep that in mind. Here, showing you multimodal pain management, 4 parts of the pain pathway: transduction, converting the external stimulus into a nervous impulse that is then transmitted, right, up the afferent fibers. It's modulated in the spinothalamic tracts, and of course, then we ultimately perceive it in the cerebral cortex. Multimodal pain management involves taking something from each one of those. You can see I mentioned earlier NSAIDs and peripheral nerve blocks, which affect transduction and transmission. Okay, something to think about. Some other things to think about under first do no harm. We're moving to our second point, moving quickly here. Failing to plan is planning to fail. Be familiar with what drugs you may have. I have encountered all sorts of drugs in other places, such as atacurium, thiopentol, different analgesic agents, sodium bicarb versus 3%, etc. Think about your drug choice. Lots of controversy back and forth, this, that, the other. Lidocaine for TBI kind of gone out of favor. However, etomidate and ketamine used to not be in favor. And of course, the physiologic evidence is showing that for rapid sequence intubation, both of those are fine relative to their effects on the neuroendocrine system, okay, and cerebral perfusion pressure. Do be aware you may be using different units. And of course, resource limited environment, that is the definition of a mass casualty, right? Our needs outstrip our resources. So get the most out of what assessment tools you have. Cannot emphasize pulse oximetry and possibly colorimetric capnometry enough. If you can get it, point of care testing, iStat, Epic, things like that. Okay, consider POCUS, right? Mine's behind me in the closet there, but I own multiple point of care ultrasound units for various reasons. I can use it for vascular access, peripheral nerve blocks, musculoskeletal assessment, pulmonary assessment, right? I can see developing ARDS by finding B lines, right, on my intercostal windows, et cetera, et cetera. Also under first do no harm are alarms, right? We basically have 2 kinds of alarms: low pressure, high pressure. Low pressure, open circuit. High pressure, I'll go over it on the next slide. Something to remember with alarms, especially your high pressure alarms, your differential diagnosis. Anytime your patient connects to an outside system, that system becomes part of your diagnosis. For example, if you have a lab value that's out of range, one of the questions you need to ask is, well, is this actually physiologic or is it a specimen handling error? Right? So same thing with the vent. You get a vent alarm, it's like, is it the meat or the machine? Is it the patient or the ventilator? Okay? One of the first things we'll often do with that differential diagnosis is pop the patient off the vent and manually ventilate. Okay? Bag valve mask, whatever you have handy depending on your role, right? There's different ways to give breaths manually. Lung protective ventilation, gave you a big slide on that earlier. Okay? Something to think about. Remember, CO2, 2 sides of a coin, right? If we are talking about traumatic brain injury, running our CO2 low can actually help improve cerebral perfusion. We just don't want to run it too low. And again, work with the tools you've got. If you have capnometry, real-time waveform, great. If you don't, colorimetric, okay, etc. Here showing you those high-pressure alarms. Remember the example I gave you of a straw and a balloon. Okay, your high pressure alarm, your peak inspiratory pressure, that's your high pressure alarm, right? Really, we don't want that more than about 30 to 40 at the absolute max, okay? And that's a combination of air going through the straw, the upper airways, and the balloon, right? The lungs, thoracic cavity, the diaphragm, okay? Here I show you pressure versus time of a volume targeted breath. Now, what I want you to do while you're listening to me is take a breath and hold it. Okay? You just, right, as you were inhaling, the pressure was changing. When you held your breath, the pressure didn't change, it plateaued. And that plateau pressure is measuring the compliance of the lungs and chest wall. Okay? When your high pressure alarm goes off, right? And you go, okay, is it the meter or the machine? Is there a vent malfunction or is there a patient malfunction? So then you start doing these inspiratory holds on your vent. And again, I'm using really basic terminology, different vents. They'll all have some way of doing it, okay? You're doing the inspiratory hold, you're measuring the P plat. What you're looking to see is if your P plat is changing, if your plateau pressure, P plat, is changing. If it's holding constant, then you've got a resistance problem. It's in your straw. You've got secretions. The patient needs a bronchodilator, something like this, right? They're bronchoconstricting. If your plats are changing, it's a compliance issue. You've got worsening ARDS, right? They're burned. They may need an escherotomy, things like this, okay? Boom, boom. Give you some definitions there, clinical relevance and application of that high pressure alarm. And again, first do no harm. What are the alarms? They are the guardians at the gate. That high pressure alarm is what keeps us from causing barotrauma or volutrauma by overinflating the lung, okay? So clinical relevance and application, peak and plateau, it's a compliance problem. And I give you several examples here. Pneumothorax, patient position, notorious, right? Because when the patient's laying flat, the contents, if this is my thoracic cavity, this is my peritoneal cavity, patient's laying flat, contents of the peritoneal cavity prevent diaphragmatic extrusion. I can't make my thoracic cavity as big, the compliance goes down, the pressure goes up, the alarm goes off, okay? That'll also affect trigger sensitivity, okay? Well, it doesn't change the trigger sensitivity, but it'll make the vent trigger, right? Because of where the sensitivity is set, okay? Abdominal distension, same thing. Remember, with positive pressure ventilation, you're worried about gastric insufflation. That gastric insufflation can, again, restrict diaphragmatic excursion, so we need some way of evacuating that and make sure it's working. And then, of course, pulmonary edema, worsening ARDS that I already mentioned. If I don't see plateau pressure changing and it's only the peak inspiratory pressure changing, then I know it's a resistance problem, and I give you several examples of those there. Here, just a graphic showing you the difference that positioning makes. It literally almost doubles the functional residual capacity of the lungs, which of course is going to be huge in terms of both oxygenation and ventilation, increasing the surface area available for gas exchange, increasing the amount of oxygen you can get in, as well as increasing the amount of CO2 you can get out. Here, okay, guys, I'm triple boarded in neonates, peds, and adults, and I really believe in cross-pollination. So here is a premature neonate example, very analogous to ARDS. Here's that premature neonate, and what we're showing you again is volume versus pressure curve, right? So you can see for a given amount of volume, how much pressure it takes to inflate the lung. Hyaline membrane disease, kind of old terminology, but the bottom line is that we don't have surfactant, okay? So the bottom curve is without surfactant, the top curve is with surfactant. This is analogous to adult pathology, ARDS, right, versus non-ARDS, okay? So you can see on the bottom curve there, for a given pressure of 20 centimeters of water, I get 0.5 ml per kilo. Remember, this is a premature neonate. That's why the volumes are so small, or 0.5 ml per gram, rather. Okay, kid doesn't even weigh a kilo because, by definition, very low birth weight, right? Now, a normal baby, okay, getting 20 centimeters, gets 2.5 mLs per gram. So it's literally with surfactant is 5 times more than without surfactant. This is your lung. This is your lung on ARDS. Okay. Again, how can we provide good oxygenation without causing lung damage associated with good ventilation? I recap those strategies for you there. Okay. Medicine meant to match homeostasis, sliding into home plate here, failure to oxygenate, failure to ventilate. You may have also, type 1, type 2, you may have also heard, and I teach this way as well, right, where basically we just go head to toe and look at all the homeostatic ways that we control oxygenation and ventilation, right? Chemoreceptors triggering the firing of the phrenic nerves, etc., neurogenic, right? So central nervous system depression, right, is going to be a problem. Spinal cord injury, going to be a problem. C4, breathe no more. Upper airway, going to be things like obstruction, lower airway, secretions and bronchospasm, and of course, parenchymal tissue. That's going to be like your ARDS, and that's going to be a type 1 failure to oxygenate. So neurogenic would be mostly failure to ventilate. Think about drug overdose or spinal cord injury, things like that. Upper airways of physical obstruction that usually restricts oxygen moving in. Lower airway, we typically see issues. It becomes a catch-22, starts out with air trapping, interthoracic pressure builds up, and my hypercarbia can lead to hypoxemia as well. Smith's P's, not going to go into them in detail. We're touching on them tangentially. Whenever you're learning a disease process, the 3 most important things to know. Again, we're trying to make it simple. Keep our thinking clean. Steve Jobs, Einstein, 2-year-old, right? What are the 3 most important things to know about any disease process? What does it look like? How does it take my patient away from homeostasis? How do I get the patient back to homeostasis? So how does it present? What's the pathology? What's the palliation? That's what we've been discussing, okay? And then, of course, the other thing to think about, positioning, okay? So failure to oxygenate, we've touched on this. I've given you the criteria. We like PEEP because it opens the airways and it opens the alveoli, right? So it promotes airflow in and out, and it also increases the cross-sectional surface area available for gas exchange. Do be aware that too much PEEP is going to cause increased thoracic pressure, which can drop cardiac output and drop cerebral perfusion pressure. Also be aware of the fact what we're calling recruitment, right? Recruiting those alveoli. You can lose PEEP in a heartbeat when you open the circuit. So we try really hard not to open the circuits or to clamp them before we open them. That's actually one of the reasons why we do inline suctioning in an ICU. Unfortunately, you're not going to see a lot of inline suctioning on mass casualty situation unless you bring it with you, okay? So things to think about there, right? It can take hours and hours and hours to recruit a lung segment, and you can lose it in literally seconds, okay? So two cautions about PEEP. I gave you some numbers for oxygen and some ways. Let's just talk about assessment presentation. Pretty simple, not written down here. You'll need to write it down if you don't know it. How do I know if my oxygenation is normal? How can I predict my blood gas where it should be, etc.? Okay. PaO2 is 4 to 5 times FiO2. PaO2 is 4 to 5 times FiO2. Okay. So if I'm breathing 21%, my blood gas reading should be between 84 and 105 at sea level, etc. Okay. Then there's another relationship here based on the oxyhemoglobin dissociation curve, okay? And that is that your blood gas reading correlates to your pulse oximeter reading. You may not have blood gases in a resource-limited environment, but if you've got SATs and you know your FiO2, you know where you should be in the middle, and if you're not, then you know you got a problem. And how would you know if you're not? Very simple. If you're going up on FiO2 and your SATs aren't improving, right? Houston, you have a problem. But I want you to think about the physiology, right? It's not just, oh, well, of course, I go up on my FiO2, my SAT should improve. No. Because why do your SATs improve, right? Why do they improve? Very simple. I take oxygen in, it crosses the alveolar capillary membrane, binds to red blood cells. Then I've got that pulse oximeter on that fingertip, right? And what's it doing? It's shining 2 wavelengths of light, right? Differential infrared spectroscopy. One wavelength of light corresponds to oxygen bound to hemoglobin. one corresponds to unsaturated hemoglobin. This is excluding toxicology and other things that combine to hemoglobin and give you a false positive if you're not using co-oximetry. Just talking about regular pulse oximetry here, okay? So this relationship, 30, 60, 90. So for a blood gas, for a SAT of 60, your blood gas reading's 30. SAT of 90, blood gas reading's 60. SAT of 100, blood gas reading's 90. There's an easier way to do it. That's how we teach it in the anesthesia world. I was trained by anesthesiologist and nurse anesthetist. There's an easier way to do it. 4, 5, 6, 7, 8, 9. Okay. So for example, if you look here, right, I'm pointing at the screen. If you look here, 40, 50, 60, 70, 80, 90. 30, 60, 90, you might get that backwards in your head. 4, 5, 6, 7, 8, 9. I think you got it. Okay. Boom, boom. And of course, that just correlates to this oxyhemoglobin dissociation curve. So for example, for a SAT of 90, if I go over to this curve and down, I hit 60. And of course, the way you can think about this, remember, this is your blood gas reading. So you can think of this as free oxygen in the serum, and this is bound oxygen in the serum, right? Oxygen not associated with hemoglobin, oxygen associated with hemoglobin. So 90, 60. This is why our criteria for failure is where it's at. Use the 2 rules I gave you, okay? On room air, my blood gas reading should be around 90, right? 95, actually 95 to 100, right? Because 4 to 5 times FiO2. Blood gas reading should be 4 to 5 times FiO2, okay? So I should be roughly at 100 on room air. Blood gas reading of 100. Well, blood gas reading of 100 means I should be satting 99, okay? This also explains why you don't let your patient sat 100 to avoid hyperoxemia. Another lecture for another day, because this curve, of course, plateaus. So yeah, my blood gas reading on room air should be 100. So if it's at 60, which is where it would be if I was satting 90, if it's at 60, that means I'm at 60% of normal, okay? There's also another problem with this, is see how this curve very gradually goes down, but then when it hits 90, it drops like a rock, okay? This represents your reserve. So you're very slowly declining. The time you get to 90, you got nothing left. Game over, done, okay? Boom, boom. So that's why the criteria for failure is where it's at, and that's why it's so important to be proactive versus reactive. Failure to ventilate, pretty easy, CO2 35 to 45, so greater than 50, we've got a problem. Okay? I'm not even going to go over the P's for that. Here, just showing you a quick little colorimetric. Obviously, if you can get a real-time waveform, great, but we're saying resource-limited environment, you may be able to get a hold of these. And something to keep in mind is this also correlates to cardiac output. Every 10 of CO2 equals roughly 1 liter of cardiac output. It's not a straight linear regression, but it holds true at the low end of the curve. Okay, so for example, a cardiac output of 4 liters per minute, which is the low side of normal, would equate to a CO2 of about 40. Okay, so in other words, you can correlate this color to cardiac output in addition to correlating it to CO2. This is important because it assumes 2 things, right? It assumes that you have an inflated lung and that I have good blood flow, right? Ventilation and perfusion. So this can also be a great distant early warning sign for VQ mismatches due to things like pulmonary embolism, tension pneumothorax, and developing ARDS. So this can be a very useful tool from a wide variety of perspectives if you understand how to get the most out of it. Just like pulse oximeter, right? You can use a pulse oximeter to detect an irregular heartbeat, okay, which could lead you to be thinking about electrolyte levels, right? When you're in resource-limited environments, you've really got to understand your physiology and your physics to get the most out of the assessment tools you have at hand, okay? All right. Here, just reminding you again to sit the patient up. Here, showing you physical assessment, right? If I see the patient hypoventilating, I'm thinking I have a high CO2, hyperventilating, low CO2, metabolic acidosis. Remember, anytime you have a problem with the lab value, it's always one of three things, right? Production, metabolism, elimination. So metabolic acidosis is usually low bicarbonate. So what's going to cause a low bicarbonate? Production, metabolism, elimination. Broken kidneys, production, I'm not producing bicarb. Metabolism, I'm using the bicarb to neutralize an acid, or over elimination, I have a diarrheal pathology. Okay, and then of course I give you base excess metabolic alkalosis there as well. Okay, again, blood gases measure oxygenation, ventilation, and pH. You may or may not have them. I'm going to do an example with one. Okay, here I just remind you of what's normal, remind you of metabolic causes of base deficit or high anion gap. Give you your normal values here. And very easy way to do blood gases. It won't work all the time. It's a trick. I hate tricks, but it's a good way to get people started. And it also helps, you know, if you're in a crunch. I tell people all you got to do is write down 3 numbers, draw 3 arrows, and you can interpret the vast majority, and then look at your oxygen. Write down 3 numbers, draw 3 arrows, look at your oxygen. You can interpret almost any blood gas out there. Okay, 3 numbers, pretty simple. pH 7.35 to 7.45, 40 right in the middle. CO2 35 to 45, 40 right in the middle. Bicarb, I like my bicarbs on the high side just because it's a distant early warning sign of acute kidney injury, things like that. So I like to use a bicarb at 25. Okay, so all you got to do is write down 3 numbers and then draw an arrow. Is the value higher or lower than your baseline number? Okay. So for example, if I had and in the United States, they refer to this as naming the baby, right? Because in the US, depending on your sociocultural background, our children often have 3 names: first name, middle name, last name, just like a blood gas, right? First name is compensation, middle name's cause, last name is pH status. So for example, if I had a child that, an adult, somebody, whatever, say it was a mass casualty situation and I accidentally narcotized a patient. So now they're breathing slow and shallow. They got a neurogenic issue, right? They're breathing slow and shallow. So what's that blood gas going to look like? Slow and shallow, I'm going to have a high CO2, right? Remember, the lungs are fast, the kidneys are slow. So the bicarbonate's not going to change. So I would have an uncompensated, CO2 is an acid, bicarb's a base. So I would have a uncompensated respiratory acidosis. And I'll give you an example with numbers in a minute. We'll throw some mass casualty stuff in there and bring it all home. Okay. Here, just a mnemonic on how to get the middle name. Again, I'm not a huge fan because it's just basic logarithmic math. It'll work every time. So here's a case study for you where we're going to put it all together, slide into home plate, give you some references, remind you you can contact me if you want more references. So history and physical, and we're going to say we can get a blood gas on this patient, even though we often can't. Just depends on the situation. We got a concussed patient, confusions, soot in the nares, broken ribs. We get a blood gas. Now, 7.25, 55, 60, 25. Let's write down some numbers, draw some arrows, look at the oxygen. pH, I'm going to write down 40. Normal pH, 7.40. CO2, I'm going to write down 40. Normal CO2, 40. Okay. Bicarb, I like my bicarbs high. I'm going to write down 25. Now I'm going to draw some arrows. Okay. pH is lower than normal. So my baby's last name is acidosis. Let's look at compensation. Compensation is very easy, guys. If your CO2 and bicarbonate arrows are pointing in the same direction, compensation's occurring. Okay. If the CO2 and bicarb arrows are in opposite directions, it is uncompensated. If compensation's occurring, I look and see is my pH within normal range, is it fully compensated or partially compensated, okay? In this case, I draw my 3 arrows, CO2's, pH is low, CO2's high, bicarb's normal. So pH is down, CO2's up, bicarb's not moving, okay? So what does that mean? pH is lower than normal, my child's last name is acidosis. Child's first name, CO2's up, bicarb's not moving, they're not moving together. I have an uncompensated acidosis. Then when I look at that uncompensated acidosis and I compare my pH and CO2, pH is down, CO2's up, respiratory opposite, I know I've got a respiratory problem, okay? And of course, there's some inhalation injury, there's some trauma, you know, possible traumatic brain injury, etc. So we've identified the problem here. What are we going to do about it? Well, what's this patient's projected clinical course? They are breathing on their own, so we could consider starting out with non-invasive, but I've told you something very important that would seemingly contraindicate that non-invasive, and that is that you see soot around the nares and lips, okay? So we're probably going to want to go ahead and intubate this patient before their airway starts swelling, because the earlier we intubate, the larger the tube we can use, the more easily we can ventilate them, the sooner we can extubate them without any, with a reduced risk of ventilator-induced lung injury in between. So my endotracheal tube, right? I want to intubate early so I can use that larger endotracheal tube. Drugs, things that I want to think about with the drugs, I already mentioned. Lidocaine pretty much fallen out of favor for pre-medication. Ketamine and etomidate might be good ideas to consider those in this patient, particularly if we are worried about them being hypotensive, because of course if we used another sedative, it could cause it could drop the blood pressure even lower and cause cerebral perfusion to take a hit. We're definitely thinking lung protective inhalation in this patient for two reasons. We have inhalation and we have broken ribs, possible pulmonary contusion. CO2 and oxygen targets, again, we're going to balance those relative to how the patient's course evolves. Okay. Here, just wanted to remind you, it's not always all about the mechanical ventilation. This is an actual patient that developed a metabolic acidosis, presented with diarrhea, hypotension, was resuscitated with normal saline, which of course caused what? Hyperchloremic metabolic acidosis. Primary consideration in resuscitation and hypovolemia is we always replace what was lost, okay? This patient lost bicarbonate and potassium in their diarrhea. Normal saline doesn't carry bicarbonate or potassium, so giving them normal saline actually caused hemodilutional electrolyte abnormalities. Something to keep in mind in these mass casualty situations. Okay, bullets, take-home bullets. I've already said these several times. Straw balloon, resistance compliance, low pressure, going to be an open circuit. High pressure, we have risk for ventilator-induced lung injury. The high pressure alarm is either going to be resistance or compliance. How do I diagnose that? By doing a plateau pressure. I do the plateau pressure. That tells me if it's a resistance or compliance problem. I see compliance issues. I start doing things to relieve that. 4 ways to improve oxygenation: increase FiO2, inspiratory time, inspiratory pressure, and PEEP. 4 ways to improve ventilation: expiratory time, expiratory pressure, respiratory rate, and tidal volume. Okay? And you'll find those things labeled almost exactly that way on almost every vent. Okay? Head to toe, we already went over neurogenic, upper airway, lower airway, parenchymal. Resources for you. Here's a totally free resource on peripheral nerve blocks. Some great lectures on recruitment and lung zones. And that's why we prone, right, to improve recruitment. That's especially valuable in a resource limited environment where you may not have things like APRV. ArtsNet Network. Here, totally free mechanical ventilation class from a wonderful colleague, Susan West out of Harvard. It does say COVID. Guys, less than 10% of this is about COVID. So if you're new to mechanical ventilation, go to edX, HarvardX, and sign up for mechanical ventilation for COVID. There's no CME associated with it, but it is great education, okay? Also, Dr. Sala has a great collection of totally free lectures, simplified ICU and critical care approaches, totally for free for download off of Facebook, okay? Or you can email me and I'll send them to you. Open Pediatrics has a wonderful vent simulator. You got to create an account. Don't let the pediatric part throw you. They have an awesome adult ARDS simulator on here. Last but not least, in terms of resources, you are welcome to reach out to me, either to collaborate, to request the curriculum that I put together for the Guyana Ministry of Health, or just for a collection, a compendium of event resources. You got my email, you've got my Facebook. Again, leaving you with a few thoughts. Remember, when it comes to education, Not the learning of facts, but training the mind to think. Don't try and memorize mechanical ventilation. Understand the physics and physiology of what we're trying to accomplish, and you'll master it. Okay? Be a clinician, not a technician. Remember the 3 H's. Always stay humble, hungry, and hardworking. I gave you 3 P's. There's 3 H's. Many thanks for your gracious invitation and attention. Please don't hesitate to reach out to me. Thank you. Thank you very much. Really appreciate you.